I shall do. Thank you, Dr. Sparias, for the kind invitation, and Dr. Patakos, dear Chairman, dear colleagues. There's obviously two groups of tricuspid valve disease patients. One is the congenital patients, the congenital population, mostly Epstein and tricuspid valve dysplasia, and other more complex lesions such as tetralogy of Fallot operated or complex AV valve surgery who have ended up having significant tricuspid regurgitation or even stenosis. And then there is the acquired tricuspid valve disease, mostly rheumatic tricuspid valve, who've had possibly bioprosthetic tricuspid valves implanted, also endocarditis on the tricuspid valve carcinoid, and flared leaflets caused by trauma, or from pacemaker leads and fibrosis of the leaflets. So the tricuspid valve, which recently we hear in most recent years that we call it the forgotten valve, is a valve that we more recently recognize how important it is, as with the right ventricle as well. The tricuspid regurgitation is a prevalent valve condition with an estimated 1.6 million people in the States living with moderate or above severity. However, only 8,000 of those patients will have tricuspid valve operations per year, and functional TR is predominantly what's developing because of left-sided lesions, as you know. And so the severe tricuspid valve regurgitation is worldwide a cause for significant morbidity and mortality. The most important problem for the morbidity and the mortality associated with tricuspid valve regurgitation is the fact that these patients come to us quite late at advanced stages, and indeed, when they go to surgery, their mortality risk is above 25% at 30 days post-op. And even when the tricuspid valve surgery goes well, it has been noted that there is a significant degree of recurrence. So as you have heard throughout the day, there are more and more percutaneous therapies for the tricuspid valve that have been applied in most recent years. Now, what kind of symptoms will the patients have? Well, they mostly come with severe shortness of breath, ascites, New York Heart Association 2 or 3 or more, atrial fibrillation, liver and renal dysfunction with associated electrolyte disturbances, because obviously they've had to have a lot of diuretics and most of the times IV. So when there hasn't been an implanted bioprosthetic valve, there is several therapies, MitraClip, Forma, etc., that you know better than me. But when there has been a valve or a ring in the most recent years, there's this newer and very safe technique of valve-in-valve or valve-in-ring implantation. And the first valve-in-valve therapies for tricuspid valve were applied with the Melody valve. This is a valve that we mostly congenital interventional cardiologists are acquainted with, and that is because we use it for the pulmonary valve. And so most of the early applications of valve-in-valve were with the Melody in congenital patients, and in most recent years, more patients will also have Edwards valve, and I'll talk about it too. So when do we replace the tricuspid valve with a percutaneous valve? We replace it when we have severe TS or severe TR or mixed disease. The patient obviously needs to be symptomatic, ascites, as I said, shortness of breath, liver or renal disease. And this is probably the first patient that in Greece that had this therapy. He was a patient of mine, 17 years old, with Epstein's disease, who's had 2 tricuspid valve bioprostheses. This valve was 5 years old and it had degenerated with severe TS. He had severe ascites, shortness of breath, and we implanted a Melody valve at Mitera in 2011. This was the final result. He lost 7 kilos in weight in 1 week. That was his ascites. And his valve, his most recent follow-up, 8 years down the line, his valve appears as it was the day after. And this was another valve that we also did that same year, and that was a perimount valve in which we put a Melody valve. And of course, later on, we started putting in our congenital population also Edwards valve in the tricuspid position. Until more recently, we get more patients with acquired tricuspid valve disease, and this was a patient of Dr. Sparia's group who had rheumatic valve disease. He had 2 valve replacements, one in the aorta and one in the mitral, that were actually functioning very well. And in 2013, he had tricuspid valve replacement with a Magna 27, which now had mixed disease, but mostly regurgitation. And as mentioned above, as with the rest of the cohort of these patients, he had atrial fibrillation, chronic anemia, and renal disease. This was the image of his tricuspid valve, which you can appreciate how stenotic it was with regurgitation. These were the beautiful imaging that Dr. Chrysocheris was doing for us during the case. And this was the implantation of the Edwards valve in the tricuspid valve position, with the other 2 metallic valves being here, and with this being the final result. So, as you all know, there is an international registry where we put all our valve-in-valve cases so that we get some meaningful results of these rare procedures. This paper came out by Dov McElhinney in 2016, looking at the treatment and the outcomes from that multi-center study, and then a further follow-up this year about the midterm outcomes of the valve-in-valve therapy and also the valve-in-ring. And it's very important to note that at 3 years, the 3-year incidence of death was 17%, reintervention 12%, and valve-related adverse outcomes 8%. And what might happen to the valve? We might get endocarditis on the valve, or thrombosis, or significant dysfunction. But 64% of patients were estimated to be alive and without any further tricuspid valve intervention at 3 years follow-up. And this patient is from our congenital population, patients with Epstein. A lot of patients, 81 patients, and 34 of them, 42%, were in New York Heart Association class 3 or 4, which is what I mentioned earlier on, that when they end up coming to us for therapies, they are at quite advanced stages. And the most common lesion was tricuspid regurgitation, and because they are congenital patients, as I mentioned before, most of them, 64%, received a Melody, but they had thrombosis, they had endocarditis, and they had some valve dysfunction, but at small numbers. And how do we avoid that? We now give them aspirin for life, as we also do with the Melody valves in the pulmonary position. And now moving on to the valve-in-ring implantation. As you know, the tricuspid valve ring is a very common procedure that the surgeons will do at the time of mitral valve repair, left-sided tricuspid valve regurgitation. And this is a paper from 2 years ago, 22 patients from 13 sites who had valve in tricuspid valve ring. And it's interesting that this had very significant success rates, no procedural deaths, and only 1 valve embolization that required retrieval. But what is important from this paper is that they had 30% of paravalvular leaks, and that is a very large number. Now, why was that? That was because the ring, as you know, is incomplete, and the site of the paravalvular leak was at the site where we don't have a complete ring. And this was treated at the same time in half of these patients, at the same time with the valve in ring implantation with the occlusion devices, and the other half came back for a second procedure. So McCarthy, who, as you know, is a surgeon, commented on that paper that this happens for two reasons. One is because the rings that the surgeons now have in their hands are obviously rigid, and also the tricuspid valve annulus is not circular, it's non-planar. So when we try to put a circular round valve in a non-planar annulus, in an oval annulus, obviously there is not good agreement. And how are we going to bypass that? We're going to bypass that by with new rings that are coming up in the market, which are good enough for treating surgically the tricuspid valve regurgitation, but also thinking of the future, that if in the future we need to put a valve in ring, then the valve in ring will be more successful. So in conclusion, tricuspid valve and valve in ring has greatly improved our patients' outcomes. As with other valve-in-valve therapies and percutaneous therapies, they are mostly used in patients who are high surgical risk. They improve the overall surgical results. They increase the freedom from reoperations. And as I said, more therapies, surgical therapies, but also more transcatheter therapies are coming up to come and lock and match with the surgeon's approaches. But as I have found out over the past few years, I'd like to mention that I think the key to the success of these procedures is the teamwork and the imaging. So it's of paramount importance to have very good imaging before you do the procedure, during the procedure, and also after the procedure. And the team approach is of a paramount importance, because we need radiologists, cardiologists, congenital cardiologists, anesthetists, and surgeons who are all in the same boat, and they all work towards the bespoke treatment that these patients need. Thank you very much.
Dr. Zifa, congratulations, excellent talk. Just a quick question. It's well known that the bioprosthetic valves placed surgically in tricuspid position have a pretty high failure rate, and I think you alluded to that too. On the other hand, you show data that with the bioprosthesis placed transcutaneously, the 3-year data are rather encouraging. With the advent of new valves that are dedicated for the tricuspid position, do you see this pattern changing, that one might be more aggressive and prefer to put a bioprosthetic valve in tricuspid position rather than rely on methods that do not fully restore the valve?
I think the years to come are very interesting, because once we know what we can do these days and what we want for the future of our patients, we're going to modify our treatments, and we're going to modify the times that we refer the patients. Number one, we need to refer these patients earlier. Number two, the valves, as you say, in the right heart, particularly the tricuspid valve, degenerate quite early, particularly in the, in the younger population and also in the elderly. So what we have seen is that bioprosthesis in the tricuspid valve will last for about 5 years, which is a very small amount of time, particularly if you have a very young person and you give him a surgical therapy that will only last for 5 years. And that is because of the low pressures of the system, the right heart system that this valve operates within. So if you have a valve, as the patient that I showed you, that by the time of 17, he had 2 surgical valves, and for the last 8 years, he's been free from interventions, you are bound to think that you're likely to put a transcatheter valve earlier than you would anticipate in previous years. However, we need to be careful because we shouldn't overtreat. That is, the risk of endocarditis is present, and the risk of endocarditis is higher in percutaneous valves, in the melody valve, than the surgical valves. So we need to think of the benefit ratio for our patients, the age of the patient, and make it, as I said, a bespoke treatment to look. Every patient needs to be discussed individually, and that's why I think it will be very difficult to produce guidelines for these patients, not for the next few years at least.
Thank you, Dr.